Good evening. Welcome to another episode of Let's Talk About Mental Health. I'm Nels Kloster, an addiction psychiatrist in Southern Vermont.
And I'm Robert Stack. I'm a licensed alcohol and drug counselor and licensed mental health counselor. Good evening. And I want to remind folks that if you have any questions or comments that you would like to send to us to the show, it's letstalkaboutmentalhealth@gmail.com or text us at 802-490-3590.
And we also have a site on Facebook at facebook.com/letstalkvt, and that is case sensitive. Yeah. So tonight in the studio we have our good friend John Moran as our guest. John is a representative from Windham-Bennington, and we invited him to update us on the activity in the legislature, which just opened up a couple weeks ago, and particular focus on mental health and addiction issues. Welcome, John. Thanks for coming in.
Well, thank you. It's a pleasure to be here, Nels and Robert, and good to see you again. I represent 7 towns in Windham and Bennington County, and I serve on a committee called General Housing and Military Affairs. And it's very appropriate that we talk about the mental health system because Irene forced a question for all of us to have to deal with. And we've been trying to deal with the mental health system in the state of Vermont for as long as I can remember. We had what we called the Futures Committee, which was trying to look at what we're going to do. Because before Irene, the state hospital was really so run down and so inappropriate for the treatment of people there. The staff was very good, but the facilities were terrible, that Medicaid wouldn't even cover the cost. So for about 10 years, we were losing $10 million a year just because we weren't covered by Medicaid. When Irene happened, we were forced to deal with a question that we hadn't dealt with in a long time. And we're still dealing with the repercussions of that because there are a lot of issues that releasing so many patients into the state of Vermont has caused. And so we're scrambling now in the state legislature to try to find appropriate treatment that is both safe for the patients, appropriate for their treatment, and also safe for staff members to deal with the patients who were dealt with at the state hospital. We're closing in on a new hospital in Berlin, right next to the medical center there, but that will only cover 25 beds. The Brattleboro Retreat has taken on a lot of the weight of the problem by taking patients into the retreat. They now have a 14-bed unit at the retreat, which is specific for the patients from the state hospital. They were dealing with patients there before they had that facility, and that caused some of the problems that we're having, not just at the retreat, but in emergency rooms and also just in the general mental health system. So we're being pushed to look again at this problem, and we're also being pushed to look at some of the issues that have grown up during the years with this problem. I remember I was up in the State House back in the 90s, and Tom Costello was chair of the Judiciary Committee, and they were having a hearing that day that I was there on involuntary medications. This was 20 years ago.
Right.
And I am, by the way, as Robert is, I'm a licensed alcohol drug counselor. Have worked in the field of alcohol and drug addiction with severe psychiatric patients for the last 35 years. I also have a master's in public health, so I bring those 2 disciplines to this subject. But I remember when Tom asked me if I wanted to sit in and testify to his committee, and I was scared. I didn't know, testify to his house, so I didn't. But that question was still there. It was there then, and it's there 20 years later.
Last night on 60 Minutes, they had a beginning show, segment, if you will, and it talked about, first of all, there was a governor there. He talked about his son attacking him and then committing suicide. I don't know if you're aware of this, but then they interviewed a group of mothers whose children, I guess, were trying to, and the point they made was that there was no way to keep them in the hospital effectively. Especially those that were covered by private insurance. And they were all in the emergency room. There were no beds anywhere. They couldn't place them anywhere, and they were getting pressure from insurance companies to discharge them. They're no longer a danger to themselves, and they were being discharged. And quite frankly, normally when you listen to something on 60 Minutes, you keep waiting for the solution. But they never mentioned what the solution was. They just said, this is a big problem. The beds were all full. They used Yale Hospital as an example. So I wonder, do we have the same problem here in Vermont where we literally don't have facilities available to people who show up in emergency rooms?
And I think we've had the problem for a long time, and part of the problem we'll have in the future, because one of the painfulnesses of behavioral health, we're talking about mental health, substance abuse, whatever, one of the painfulnesses of that is it's always a family illness. It just doesn't stop with the person who is suffering the addiction or the mental illness. And as a matter of fact, being a family member of someone with these kind of illnesses is so painful, and I saw that episode. It was very painful to watch. It's so painful because at some point it actually starts to affect the mental health of the people close to it. For example, in the field of alcoholism, you had Alcoholics Anonymous, but you also have Al-Anon for the pain and suffering of the family members of the alcoholic. We have NAMI, which is the Association for People who are dealing with people with mental illness. That was the senator or representative. Senator was, I mean, you could see the scars on his face from what his son had done to him. And it wasn't that there wasn't love between the two. The son was a schizophrenic whose illness went completely out of control. The answer to your question is, and this is what the big argument is, the rights of an individual to live his or her own life and to not be made to do something they don't want to do. The problem is if that person is suffering from mental illness or a severe substance abuse problem, they are not only in trouble with themselves in terms of the illness, they have complications at how it affects their family and society. And this argument, as I say, 20 years ago when Tom Costello was asking, and we're still asking now, where does one's right to determine their own destiny in terms of treatment and where does society's right to step in and say, you have to accept treatment because you're a threat to yourself and to other people.
Right.
But,
Go ahead.
What I'm saying, and Vermont's approach to this is quite a bit
Yes.
away from the average of what other states are doing, more towards, say, protecting the liberties of psychiatrically ill patients, as opposed to sort of, stepping in a little later with the process of involuntary medications. And I've heard that maybe this connects to our seeming lack of facilities. That because we are, after all, depriving these patients when they become dangerous of their liberties, and then by warehousing them in a sort of state hospital setting and not being allowed to treat them. So is that, trying to kind of bring that together, is that the focus in the legislature right now?
yes, it is. And you're right. The Vermont probably has a more stringent protection for the rights of the individual in the sense of stretching out the court procedures and whatever. My understanding is a lot of their places are much more expeditious in terms of this problem. And we have people on the mental health advocate side who strongly want to protect the rights of the mental health advocates. I have a fellow representative who really articulates very well the needs to look out for the rights of patients so they're not forced to be treated if they shouldn't. But she is also very sympathetic to the notion that we need to find the balance in between.
Right.
And I think we do need to have some, I think there are two issues here. One is the immediate situation, and I think if someone is immediately out of control, we have some mechanism to force medication if we have to, and to bring them within control. The other thing is, though, once they're not acting out, where do you find that balance between keeping them on medication so they don't act out in a sense that's dangerous to themselves or other, or when you don't? I think we are heading in a direction that we're going to be probably trying to be more compliant with other states to do this. But it is never an easy choice. See, I'm a member of the American Civil Liberties Union, and I'm also someone who's very concerned about staff safety. One of the things I haven't gone into a little detail, which I would like to, is because of the emptying of the hospital, in this case because Irene, it happened years ago called deinstitutionalization. This was sort of a natural cause for deinstitutionalization. We have staff, nurses, mental health workers, counselors, doctors, who are sometimes put in severe danger because of the patients who are not getting the appropriate contained treatment they need.
Yeah.
And so it's a balance between staff safety, public safety, patient safety, and the rights. I think we are moving in a direction we're going to come up with a more I think the pendulum is sort of swinging in the direction that we need to be a little stricter than the other states in this area.
Yeah. And I know that from having...
But I don't want to predict what 150 representatives and 130 senators finally decide.
Yeah. But I know when I was in my psychiatric residency, I did a lot of moonlighting at the state hospital. And I think one thing that gets lost in this is there's quite an expertise. Again, you talked about an antiquated facility, but that the staff there was quite expert, experienced. And that makes a real difference. I think there's sort of a tradition or an institutional memory that comes with that sort of thing, that from generation of training upon training with new hires, that you're more aware and you just have you're more skilled at working with it. And I think that credit to those who have stepped up to try to help, but quite often there's a gap between what they're used to doing and what this new population requires for them.
Absolutely. As a matter of fact, the staff at the state hospital, once the new state hospital opens, I think they have some options to return. But it's been a few years, so many of them have moved on because they have to support their families, and these aren't the best paying jobs in the world either. Always in the human service and the healthcare field, you don't always get the best paying jobs for people who are doing probably the most important work. And you're right, there was a culture in the state hospital, even though the facility was not up to par, the staff was. There was a culture there that will have to be recreated. For example, when Berlin opens its new hospital, hopefully 25 beds, there's some argument about 16 versus 25 beds, then it will start to create a culture of dealing with Class A patients, the number one patients they're dealing with. And even at the Brattleboro Retreat, I think they have the unit on the fourth floor that will maybe develop a culture to deal with this acutely needy population of patients. But it'll take time for that culture. But now, currently what's happening is you have people in the community and people in emergency rooms and trying to deal with who don't have the culture of dealing with these patients. Yes.
So, John, I'm a strong supporter of the single-payer idea, and I really think it's the answer for Vermont. I would love to see us lead the way, I mean, quite frankly, and I think it's doable. But one of the things that sort of strikes me is that they talk about the economics of it, getting paid for it, how that's going to work, who's going to enroll, and all that. I wonder if there's any chance that we would actually take a moment to talk about how we provide mental health to Vermonters, how we provide services. And so instead of thinking about it as the state becomes the last course of intervention in a crisis situation, and it looks that way sometimes, rather than thinking about treating somebody with severe, let's say a teen that gets diagnosed with bipolar or schizophrenia at 18, 19, have a different system in place rather than waiting for that moment when they end up in the state hospital, they end up on a locked unit, they end up like a... So is there any thought at all of changing the way we provide services, not just how we pay for it, but how we provide services?
I want to back up just for a second.
Sure.
The reason I got into politics to start with, or ran for office, got involved, was because of healthcare. I remember living in Wardsboro, and I remember some family member in the town below me, Dover, got ill and suffering from cancer, and there was an entire community holding fundraisers and things like that to raise money to get treatment for this person. And I thought, that's our responsibility as a society, as a culture, that not to put it upon people to have raised money because someone gets sick. I know I'm not talking about mental health right now, but I think the whole concept was, first of all, healthcare is a human right. I have no argument with that, and everybody should have a right to the best healthcare possible, regardless of income, whatever. I was part of working towards parity, which was one step to get towards it, because there was a time, and it's still a case to a great degree, but there was a time when mental health and non-mental health treatment were totally different entities. There was no question about repeat heart attacks. You had a heart attack, you got treated. You had another heart attack, you got treated. Whereas with mental health, it was like 1-2 times and then that's it. So I think one of the steps in correction was parity, which we do have in the state of Vermont, and it's also in the national health care law. But in terms of your question, yes, I think we need a system that makes no differentiation between the needs for mental health treatment or the needs for physical treatment, and we need to create a system that treats all of them. I'll give you a classic example. This is a wonderful example. My committee, as I say, is general, which covers things like, we cover everything nobody else picks up, but we also oversee the Department of Liquor Control. We also oversee lottery, which are a couple of addiction areas. We also are housing, so we look at the housing, and a lot of mentally ill people are homeless because of their mental illness. But we also are military affairs. And why I mention this is, I was at the VA hospital a couple of weeks ago. We went on a field trip there. And what they have done there, which is so beautiful, is on the unit at the VA hospital, as they talk to people on medical issues, like I'm there for high blood pressure or for diabetes or whatever, if I even mention the word like PTSD or I'm suffering from any kind of psychological or emotional problem, they don't give me an appointment 2 weeks from now to talk to someone. Immediately someone comes in and talks. They pull someone over, and a counselor sits down to me and starts talking to me. So it's an integrated system in the VA hospital that they treat medical and mental problems exactly the same, and respond immediately on the spot to it, because they see the interconnection. And so I see that kind of model would be very wonderful if we could expand it. Maybe it didn't answer your question.
No, but again, that's a great example. If you thought about the VA system in New York or Philadelphia or whatever, the number of people they treat are probably the equivalent of the state of Vermont.
Yes.
I mean, and that's exactly what I'm thinking. But I'm thinking more preventive, more integrative, over a long period of time. Quite literally a different culture of treating mental illness, a different way of thinking about it. So anyway,
I mean,
go ahead.
More preventive, I guess, right? Looking at sort of earlier intervention, doing things in schools, for example, teaching families how to encourage good mental health.
Yeah.
You know, one of our first guests on the program this season was Mary Ellen Copeland with the RAP program,
Yes.
Wellness Recovery Action Plan. And we did not push her on a position around involuntary medications because with that sort of program, you're looking at sort of ways of getting patients involved in their own care, being proactive, taking responsibility, being educated, having support networks. And I think everybody agrees that I don't want to call it failure, but we're certainly not pleased when it gets to the point where we're talking about depriving someone of their liberties, involuntarily hospitalizing them, and argument involuntary medications. So again, how do we make sure that kind of an approach is part of our mental health system? How do we have a full spectrum here that hopefully is more weighted towards that sort of prevention and wellness end, so we don't have to have such emotionally intense conversations about issues like involuntary medication?
Right, and I'm very sympathetic to the concept of prevention, and I think part of the education, I'm thinking now, for example, in the substance abuse field. You know, we know there's certain signs that people, first of all, are heading towards problems with drinking, blackout drinking, that kind of stuff, heavy drinking for young people and everything. But if you try to tell them, stop drinking or don't do it, I don't know how far you'll get. But if you let them know, what we're seeing at this point in your drinking, if you keep drinking, this may take you here and here and here. And if they start to get here or here and here, then they may start to reach a point where they say, wait, I don't want to continue doing this. And I think we could do that with mental health, mental illness, a lot of things. There's so much people get caught off guard with schizophrenia when it happens, but there's signs in terms of when people leave home and move into the college level. So we could educate people to say, this is not the usual thing that happens to somebody, and why don't you check in and see? Because schizophrenia even is very treatable once people start to get into it and start to do something about it.
And if you could treat it early, and if you can hold the episodes down, I think there's less reoccurrence.
Yeah, because when people have breaks and become sort of floridly psychotic, there's actually degeneration in the brain, which then has devastating effects on their cognition and their personalities after that.
I don't want to minimize the importance of substance abuse in the mental health system, because a lot of times, for example, with schizophrenia, the only measure of rehospitalization is if they drink or drug, if they use substances. A lot of times, many of these mental health conditions are very manageable and treatable. What precipitates a rehospitalization often is the misuse of substances, which interplay with them very often. So in my committee sometimes, we keep getting bills to ask us to lower the drinking age to 18 or something. Well, we now know that the brain is still developing up to age 25. So my response is maybe we should raise the drinking age to 25, but that doesn't go too far. No, it won't go very far at all. But I'm saying that we have to understand what we're dealing with in terms of developing brains, and whether it's substance use or whether it's mental health problems.
Yeah. Well, and John, you're working to be a champion for poverty and increasing opportunities for people who are struggling with poverty right now. And there's a soon-to-be released study that looked at Cherokee Nation and what happened when they started the casinos. And what they had done was they made the decision that they were going to take this money, reinvest it in the community. And I think, was it $6,000, $8,000 per family then, went straight to them as like basically no strings attached, sort of stipend every year to the families. And what they found when they tracked the children at varying ages, that the younger that this stipend came into play, there was a significant decrease in the presence of alcoholism and other mental illnesses by the time they got older. So people always realize the hardship of poverty and the impact of it, but this was a study that's finally sort of shown not just a correlation, but maybe some kind of causation, that poverty does create mental illness and addiction.
I think it surely exacerbates it and makes it a lot worse. As a matter of fact, one of the arguments we're hearing about the causes of poverty are mental illness, substance abuse, and I think they're not the causes of poverty necessarily, because the rich could have mental health issues and substance abuse issues. We know that. I think they are the consequence to a great degree. I think mental health and substance abuse have a life of their own, an entity of their own, but the added pressure of poverty and homelessness and all the things that go with it just exacerbate it and make it worse. Yeah. So to me, the only singular cause of poverty is low income. As the study that you just said proved, that if you increase the income, the usable cash of the person, their lives are better. And so what I want to do is understand how debilitating poverty is and the economic inequality that happens in this country right now, and how if it doesn't cause many of the mental illness and substance abuse, it surely makes it worse. And I think it's a deadly combination.
Yeah.
You mentioned substance abuse, and I wonder if I could ask you, the governor stated a state address, and he's focused on opiate addiction. And I was wondering if you had any more information about that, because last week I mentioned I was sort of interested exactly how they're going to implement it. What was their idea? They had this idea that they would intervene at the courts or when someone got arrested. Do you know more about that? Have you heard any more about it?
It's still in the thinking stage or the talking stage. I first would comment on the governor's singular topic for the State Address. I appreciate that addiction is a very serious problem and needs to be dealt with. I think there are a lot of other problems in the state too that didn't get mentioned at that time, which is fine. And I think in some ways we always talk about epidemics when it comes to substance abuse, heroin, cocaine, or whatever. But right now in Vermont, it is a serious problem, but there are some indicators that some of the problems are starting to be addressed. We do get more people showing up for treatment, but that may be a good sign that we're offering more treatment. I don't know what is good. I'm very happy that we're addressing this as a serious question. And in answer to your question, as far as I could tell from the governor's speech, he was talking about more money for the recovery centers. He was talking about intervention at that level, of the court level. He was talking about the notion that grab them when they're in trouble. We know that in the substance abuse field, when someone hits bottom, that's the best time they're going to do something. If they're in some kind of trouble with a DWI or whatever, they're more inclined to listen to getting help, and he's talking about doing that. He also pointed out that he sees it as a mental health, a public health problem, as opposed to a criminal justice problem. And as I say, I have a master's in public health, and I think the whole war on drugs has constantly gone the wrong way in terms of trying to incarcerate or trying to criminalize and deal with it in that way. And I'm not saying that there aren't criminal penalties for certain behaviors under the influence of drugs, but it is really a public health addictions problem. And I'm glad he's focusing on it. I'm glad there's some money going into it, and I just don't want to misunderstand or underestimate the real underlying problem that we don't want to forget is alcoholism and alcohol and its effects, because it's always there as a serious problem.
Well, yeah, no, there was I think Vermont Digger mentioned this, there was a state epidemiological work group, right, and they were looking at statistics throughout the state to find what problems the state should focus on in the addiction area. Right. And opiates were not on that list, very short list, I mean 3 things, and right, one was underage drinking, right, heavy drinking for those younger than 25, as well as use of marijuana in those less than 25. So it seems to sort of struck a little bit of a discord with this whole attention to opiates when we've just gotten started with a statewide system to address opioid dependence. And then when they focus on marijuana like this, and to have all this discussion about decriminalization and possible legalization, there seems to be a bit of a disconnect here.
Yes. I think it's often been the case of talking about one area and not focusing on the other. And as I say, the addiction is the issue, and I don't want to underestimate the seriousness of alcohol and other drugs besides the opiates. Yeah. So, it's a point well taken. Yeah. So, yeah.
Well, I know this is sort of difficult, but I just want to go back to it just a little bit more, and that is this idea that this opportunity. And there's certain decisions that have to be made about the single-payer system coming right up this year. And do you see that happening? I mean, do you see that moving in that direction? Do you think that, the governor says he's for it. Just, if you don't mind, what's your impression on that?
I'm not sure what's going to happen this year, because obviously the rollout of Obamacare, the rollout of our own health care system. There's nothing wrong with the concept of the universal health care and all that. It's just the private industry that was supposed to roll it out didn't do too well in terms of the computer programming. The issue is still around the funding. I don't know, we're still hearing different theories about how it's going to be funded. To me, it's really, it's going to be a necessary thing. It's something I want. But we have to deal with ERISA first of all, and ERISA is where private, large corporations like IBM don't have to accommodate the state of Vermont. We still have the VA healthcare system. We still have TRICARE, and we still have the Medicare system. So in some ways, when we use the word single payer, I guess what I want is universal health care. I'm not sure, for example, I'm on Medicare now. I'm not sure Vermont's healthcare system is ever going to accommodate me at this point. But given that, I think we have a large enough pool of all the people who don't fit into that category to create a viable single-payer system. What I see as the value of a single-payer system is you'll not have a profit motive in it anymore. It will be controlled by the state, maybe run by Blue Cross Blue Shield, whoever they pick to run it as the administrator. But it will take away a lot of costs that are still going out into profit that doesn't need to be going out there. And I see it as the answer to healthcare. And I don't know, I'm not an expert in the whole healthcare field, but I'm not sure exactly the details, but I'm surely going to support getting it where we need to go.
Yeah. And I mean, our system is different than any healthcare financing system in the other developed countries. I mean, most European countries, for example. I mean, a wonderful book, if you're interested in this, called The Healing of America by T.R. Reid. And insurance is not run on a sort of for-profit motive in most developed countries. There are very strict restrictions on how much they can charge and what they have to cover. So you're almost getting choosing your insurance company based on what kind of services they give you, and realizing that you will have coverage. But then, and I don't know if this is too big a topic, but the idea of disconnecting our insurance from our employment is something I've heard a lot about as well.
Well, and you're right, historically. For example, the reason we have connection with employment insurance was during World War II, there was a wage freeze. And with the wage freeze, and I'm telling you people you already know, the only way that employers could compete for employees was to offer some incentive, and they couldn't offer better wages, so they offered health benefits. So, and unfortunately, the unions went along with this to the point that instead of coming up with a universal system like Medicare or Medicaid, they came up with a system which was negotiated with employers for the health care. And if we had gone at that point and said, let's negotiate for a national health care plan and not an individual corporation type of health care plan, it would have been a different story. But you're right, we have to decouple it from employment. That whole portability is very important, and I think it's part of all the plans, that you're not locked in, because people are locked into jobs they don't want to be in only because of health care. And we need to get away from that employment lock-in. Yes.
I mean, I feel like we should have gone for an hour with this program today. I feel like we're just sort of barely scratching the surface, and we could go much, much deeper in a lot of these issues. But we really want to thank you for coming on to the program tonight. Obviously, you guys are quite busy up there in Montpelier, and this meant a lot to us for our good friend to come down here and chat with us.
Well, it's a pleasure to see both of you again. It's a pleasure to be back in Brattleboro again. But
Any final message or any comments that you'd like to make?
Well, as Nels said, I think we could talk about this for a long time. So if anybody wants to be in direct contact with me on this issue or any issues, please contact me. And I think you can reach me at my phone number. I think you may be putting up the address of how to reach me or whatever.
Right.
Well, thank you very much, John. Thanks for coming on, and I appreciate it.